Hello, good evening, everybody.
Evening
Lovely
all.
to see you. So we're here on this lovely, I know it's been lovely here anyway. Sunny Thursday, just gone dark for me here at home. And it is World Oral Health Day. So hopefully everybody's been doing some lovely things for World Oral Health Day. I have been at the coalface. Don't know about you, Lauren, have you?
No, not at the cold face today, just doing some things from home today, but um
Okay.
it's a
Okay.
good it's a good day for an evening webinar on World Oral Health Day, I think.
Yeah, definitely, of course. Yeah, yeah. So as you can see, I am not Siobhan Kelleher. I am Catherine Mayo.
Despite what your name might say.
Yeah, despite what my name might say. So we're just going to give it a couple of minutes just to let everybody sort of trickle in because I know, it's sometimes it's a bit of a dash in, try and get everything sorted, get some food and sort of sit down to listen to us. Well, not me, but Lauren talking about how to embrace the full scope of a dental therapist. So
Perfect.
we'll just
So we'll
give it
just
a
get
little.
started. We'll just let people trickle in as they manage. All right. So today we're going to be talking about reskilling. So top tips for embracing full scope working as a dental therapist. So we're going to talk about the steps that you can take towards reskilling as a dental therapist to utilize your full scope of practice to benefit the patients, the practice, and the entire dental team. We're going to talk about having a support system on your reskill journey, how to introduce the role to your team effectively. Practice protocols are hugely important, so we'll talk about those for efficient whole team working and equipment and techniques that can simplify your restorative protocols and enhance your results. So a little bit about me, if you've never met me or heard me speak before, I have been a dental therapist for almost 17 years now, so a long time. It makes me feel very old when I say that. I've done a couple of postgraduate diplomas in restorative and aesthetic dentistry, education coaching and mentoring as well. I serve as therapist clinical director for a small dental group up here in Scotland in the north of England, Pain Free Dentistry Group. I educate for NSK, Smile Dental Academy and LM. I'm secretary for PGDip, and I also run a course called Restore, which is a reskill course for dental therapists. And we'll talk a little bit more about that later as well. So let's get started, okay? Probably most of you who are on this webinar probably know what a dental therapist is very well, but is that the case for the entire dental team? Sometimes not. Is that the case for the public? Definitely not. I think general awareness of what a dental therapist is low in the public, and as I say, even sometimes worryingly within the profession. So this is the kind of response that we often get when we say, I'm a dental therapist. You get all the jokes of, do you talk to teeth and all these silly things. But dental therapists have actually been around for a long time. So the first dental auxiliaries trained in 1959. So we're talking, what, 65, 66 years ago, something like that. Were trained in the UK. That's what we were called before we were called dental therapists. 1979, so 45 years ago, we changed our name to dental therapist. 1983, combined hygiene and therapy training began. So before that, you would train either as a single qualified dental hygienist or a single qualified dental therapist. Dental therapists could only work in community settings up until 2002. So anyone who was a single qualified dental therapist would have been found in a community setting. So it's only really for the last 22, 23 years that we've been able to work in general practice. So in the grand scheme of things, I suppose we are still quite new compared to the other professions within general practice. So that is why, we are still having to raise awareness of our role and our scope. In 2013, we had direct access approved by the GDC, so meaning that no longer having to have a prescription for everything that we do from a dentist. And in 2024, as you will all probably know, we were granted the prescription only medicine exemptions as well. So we can now train to use prescription only medicines and dispense certain ones to our patients as well as dental therapists without needing either a prescription from a dentist or anything else. So again, we'll talk a little bit more about that in a second. But this has been a huge step forward for our profession. Obviously, you know, those of you who know will know that it was worked on by BADT and BSDHT for 11 years by Fiona Sandham and Michaela O'Neill. And so it took a long, long time to get this through. So again, you know, we obviously thank them for their work, and it's been a huge thing for our profession. So our scope of practice, again, if you are a therapist, you'll probably know this, but there might be some other people on here who are not. So as a dental therapist, we can take a full clinical examination, so including prescribing and interpreting radiographs. So if you qualified, there's no kind of real cutoff, but round about 2013 or afterwards, you will be able to prescribe and interpret radiographs. Again, you need to check, you know, your undergraduate syllabus of whether you actually covered this at uni. If not, if you qualified before then, or you didn't cover it, then you can take an additional course to be able to prescribe and interpret. You can take records, including digital scanning, impressions, Facebook registrations as well. And you can diagnose and treatment plan within your competence and scope. So that's anything that is within your scope as a dental therapist, you can diagnose and you can treatment plan without the aid of a dentist. You can use local anesthetic. So like we mentioned a second ago, that can either be via patient-specific direction from a dentist. So that's where the dentist is literally writing you a prescription saying, please use X anesthetic up to a certain amount on this patient. So patient-specific. A PGD, which is a patient group directive, so a document that is signed by a dentist and a pharmacist, allowing you to use anesthetics and fluoride varnish without a prescription. Or we can now complete our exemptions training. So obviously this is quite new, but all online, you can access at any time. You can complete your exemptions training, which means you can use as and when you like for your patients if it is appropriate. So, you know, as dental therapists, dental hygienists, again, a massive leap forward for us to not have to rely on someone else to allow us to carry out our full scope. So removal of caries as well, all direct restorations on primary and permanent teeth, deciduous extractions, direct composite for cosmetic purposes as well, because again, that's just a direct restoration. Tooth whitening is still under prescription only, so there is no way to do a course or anything like that to allow you to prescribe tooth whitening for yourself. You always have to get that prescription from a dentist. And then we can obviously refer to fellow professionals for treatments that are outside of our scope or competence as well. So how can patients access us as dental therapists? So two distinct routes. We have referral and we have direct access. So referral is our traditional route. So this is, you know, what used to happen before we had direct access. So patient would traditionally see a dentist for a new patient exam or a routine exam, routine checkup. Dentist is going to carry out the full assessment, do the treatment plan. They may then refer onward to dental therapists for some or all of the items that are within our scope. Therapist will carry out the treatment. If it has been referred, you can't alter that treatment plan. You have to carry out, you know, what the dentist has asked you to do. And then the patient would usually go back to the dentist for their routine care exams. All right. But now we have direct access. So again, relatively new. So the profession is still getting used to this. So patient will see a therapist often without first seeing a dentist, or may well be a patient of the practice, but is seeing you rather than seeing the dentist. Therapists can carry out the full exam, including radiographs. You can treatment plan all the items within your scope. And then anything that's outside of your scope, you will refer onward to your appropriate colleague, okay? And we can carry out the treatment that is within our scope. As you can imagine, this does take quite a lot of logistics within the practice, a lot of excellent teamwork as well. And you're going to hear me mention the team a lot tonight because it really does take the full team to allow us to work to our full scope. So things to consider with how patients can access us. So direct access does work most smoothly if we have either a PGD in place, so the document that allows you to use local anesthetic or fluoride, or you've completed your exemptions training. The GDC advised that you don't carry out direct access for about a year after graduating, just to get your competence and your skill levels up with diagnosing and treatment planning. And dental therapists can now open a course of treatment. So that is in England and Wales only. So if you're in Scotland or Northern Ireland, you can't quite yet open your own course of treatment. England, Wales, there are still some hurdles to this. You know, we don't have financial parity, we don't have pensions. like the dentists either. So, some people have started to do it. Some people are not willing to do it, don't want to do it. That is completely up to the clinician. But again, this takes huge teamwork because we still can't have our own list numbers. You're still working under a dentist list number. So they need to be happy to have you doing that, and you need to be happy doing that as well. So again, there's a whole lot of things that need to be considered. And I think BADT definitely do. I'm not sure about BSDHT, but there are documents to guide you on working as a therapist, opening NHS course of treatments as well, if you are a member. So something to look into. With the team, the entire practice team should be aware of your scope of practice. So things like using your correct title is really important. So, often if the team members are not really aware of what a dental therapist is, what a dental therapist does, they might be calling you a hygienist or a hygiene therapist or something like that, but you want them to call you a dental therapist. So if need be, sit everyone down, bribe them with some biscuits, buy them some lunch, something like that, and just go through, what exactly your scope of practice is, how they should explain your role to patients, and how how they should be addressing you to patients as well. Anecdotally, I do know someone that unfortunately was called the incorrect title by their receptionist. They then completed a restorative procedure on a teenager, and the teenager's mum then complained because they thought that this person was a hygienist and that was carrying out fillings. So it can happen. Protocols need to be in place for treatment outside of scope as well. So things like who's going to report on a radiograph. If you take a periapical radiograph and you see a lesion, a periapical lesion on that, who is going to report on those kind of things as well. Good team relationships and communication is essential. So like I said, I'm going to talk about this quite a lot tonight. Absolutely key. With yourself, you need to outline to the team your level of competence and confidence. So what can they refer to you? If you're working on a referral basis, what can the dentist send to you? Make the patient aware of your title and scope. We'll talk about how to explain that and how to communicate with your patients a little bit later as well. Before treatment starts, including the limitations to your scope. So, always reassuring them that you do have dentists in the practice that you can refer them to if there's anything that needs to be looked at that's outside your scope. And again, good communication is absolutely key with your patients. So items outside of scope. So knowing when to say no is the absolute key to work into your full scope as a dental therapist. So even if it is within your scope and you don't feel competent or confident to do it, absolutely just refer onward to a colleague who will be happy to do the treatment. There's no worse kind of situation or feeling than getting yourself into the deep end when, something that you kind of knew in your gut that you probably shouldn't have taken on. Just refer onwards in the first place. And a protocol in place, like we say, for onward referral for outside scope treatment. So who might you refer onward to? So it's not always going to be a dentist. You might refer within your practice to an oral health education nurse. I personally don't work with an oral health education nurse, but I would really love to. I think they're a great asset to the practice. So you could refer for some oral hygiene advice to your oral health education nurse. You could refer to a hygienist within the practice. So if you saw a patient and they maybe needed periodontal treatment or they needed some sort of hygiene treatment, you could refer onwards to a hygienist as well. If you weren't going to carry that out yourself, you could refer to another therapist in the practice. So again, you may work with fellow therapists who have different levels of confidence, competence to yourself, and you may well want to refer things on to them. General dentists as well. So again, anything, involving the pulp of the tooth, you're going to refer on to your dentist colleagues or specialists. You may be lucky enough to work within a practice that has specialist endodontists, specialist periodontists, prosthodontists, any of the specialties, and kind of implantologists and things like that as well. You can absolutely refer onward. And we'll talk a little bit later about how that can be really beneficial for the team too. Outside of the practice, you might want to refer to secondary or specialist care, community services, to their GP if there are any medical issues, social services if need be, and I don't think there are any others, but there may well be some others as well. Okay. So let's talk a little bit about modes of working. So how can we make this work in our practice? There are so many different models. Anyone who tells you that they can give you a model and just slot it into any practice I personally don't believe that that works because I think every practice is different, every team is different. There are certain models, though, a few different ones that we'll talk about that can work in different practices, but it's really sitting down with your practice owners, your associates, the rest of the staff, and just seeing what works for you, really. So this is our traditional model. So this is what a lot of therapists find themselves doing when they come out of university. I mean, when I graduated 16, 17 years ago, we were trained, we all thought that we were going to come out, we were going to walk into a full scope therapy job, we were going to be doing restorative work, we were going to be doing hygiene work, we were going to be doing our absolute full scope. And sadly, that's not what happened for me. That's not what happened for a lot of my classmates either. My first job was in an NHS practice doing 15-minute scales and polishes on the NHS. Scale and polishes, I know a bit of a dirty word, but that's what it was back then. It was 15-minute scale and polishes. That was all I did, all day, every day. This is what we tend to find a lot of dental therapist books can look like. So these kind of set slots where everything is in a 30-minute slot, a 20-minute slot, depending on what your practice has implemented. 30-minute slot just every day. You might have a double session for someone that needs perio treatment, something like that. If you are doing this kind of work as a dental therapist, you're just utilizing about 25% of your scope of practice. So these are just, I tried to kind of take an average of what appointments cost across the country. This is just a very kind of average, maybe £60 for half an hour. Okay. And this is just to represent how things can improve for yourself, possibly financially, if you're working on a percentage, and also for your practice, because at the end of the day, this is what is going to help you speak to your practice owners about implementing a therapy model, because the finances do matter, unfortunately, as much as sometimes they're our last consideration. But if you were doing this for a morning, just taking a morning session as an example, you might produce about £480 in that morning session. Okay. In this kind of model, we are adding on in some routine restorative treatment. Okay, so maybe some composite restorations. So we're still doing our kind of 30-minute hygiene visits. We're adding in some composite restorations. And at this, as a dental therapist, we are using around 65% of our scope of practice. So we're getting there. Okay, we're increasing. And you can see that your production value for the morning has gone up as well. So a little bit more money for the practice and for yourself. This is the model that I work under. I have worked this way for 13 years nearly now, and I will not take any credit for that. I basically started to work in the practice that I work in now, and they were already doing this. So therapist-led model, therapists are carrying out the routine exams, perio treatment, restorative treatment, basically anything that's within our scope. So because we're carrying out the examinations, it means that we are able to, examine, diagnose, carry out the restorative treatment, and then refer onward if need be. So you might have a combined examination and hygiene visit. That might be maybe 40 minutes, something like that, depending, just for a routine patient. Then you might have some composite work, some periodontal therapy, whitening impressions, things like that. And you can see that that massively boosts your production value as a therapist as well. So 100% of your scope of practice used if you're using this model. All right. I honestly, having worked like this for a long time, I find it hard to imagine working any other way now. It's just great. And working with a supportive team, I always have somebody there. If there's anything, a patient comes in with a swelling, something like that, the dentists are always more than happy to just nip in and see the patient. So, it's proper kind of team working collaboratively, treatment planning together as well, all those kind of things. So some therapists might have carried out a lot of advanced cosmetic courses, carrying out cosmetic restorative treatment. Often this is done via direct access, not always though. Things like, doing more whitening, edge bonding as well, kind of composite veneer cases, then your routine posterior composites as well. Again, you're using 100% of your scope of practice, but again, as you can see, the production value goes up as well. All right, so this is a great way to explain to your practice, how you can help them. Kind of everybody wins, you win, they win, the patients win as well. Easier for patients to access the professionals that they need to access. So this is the question. Okay, this is what always gets asked when I do this presentation by dentists mostly. And what about the dentist? I think when a dental therapist is introduced to a practice, or when dentists, other dental professionals first learn about dental therapists and know what we do, there can be a little bit of protectionism of their work. I've had a dentist say to me, "Oh, but you're taking away my bread and butter," years ago when I first graduated. You know, it can be a little bit threatening for them. They think that we're going to take all the restorative stuff out of their diary and they're going to be left doing absolutely nothing. And that could not be further from the case if you have it, if you have your protocols in place, it's all set up properly, and they will only benefit from this as well. So if you imagine this might be your typical dentist morning, okay, they're doing maybe kind of 20-minute exam slots, they're doing a bit of posterior composite work that you could be doing. They are maybe doing the whitening imps and things like that as well, and fitting some whitening trays, etc. This is what they could be doing. So depending on what your dentist likes to do, they could be doing, kind of dentist specific things like placing implants, placing crowns, veneers, doing ortho treatment, things like that. There are so many different things that they could be doing that they might be passionate about. And don't get me wrong, loads of dentists love doing composite work and things like that as well. It's not that everything has to go to the therapist. It can be selective as well. Again, it's working together. I have dentists that I work with who really love doing composite work. They might see a patient for an initial exam. They will plan to do maybe some composite veneers for the patient, some bonding for the patient. Patient might have Invisalign before that as well. If they need kind of health treatments like posterior composites, they might refer that to me alongside maybe any periodontal or hygiene treatment they need as well. So, everybody kind of gets a share of the pie, so to speak, and it works for everybody. It allows the patient again to have better access. So, the patient can be seen more quickly often as well. If they're seeing two people and alternating their appointments. All right. So again, direct and care, we are perfectly placed in the practice, whether it is new patients, whether it's routine patients, we might be the people that see patients the most. So, if we're seeing them every 3 months, every 6 months for their routine hygiene visits as well, we are perfectly placed to talk to patients about different treatments. So, has a patient got a space that they might be interested in filling? You'll be surprised, patients don't mention things. They might have a gap on their upper left four, and they think, I'd like to do something about that, but they don't say. They come in, if they're in for a quick kind of exam appointment with the dentist that's 20 minutes long, they often just don't say these things. They don't think they have time. They don't want to bother anybody. So a really effective question I find to ask patients is, how do you feel about your smile? Or are you happy with your smile? Because often they'll say, oh, well, yeah, it's not too bad, but this bothers me or that bothers me. Asking patients about gaps, asking patients, patients that struggle to clean because their teeth are crowded, if they ever considered straightening. Obviously, no one really wants to see the endodontist, but sometimes it's necessary. They might be interested in smile designs as well. So loads of different ways that you can direct patients to the dentist. These are just some examples of direct access patients that I have seen personally where it has then benefited the dentist as well. Okay, so this lady came in, I think she was in her 40s, I think. You can see she needed some periodontal treatment. She hadn't been to the dentist, very nervous, hadn't been to the dentist in 20 years, I think, something like that. Had some old leaking amalgams. What we did for her was I did the direct composite and the periodontal treatment for her. She then had some extractions of grade 3 mobile teeth with the dentist and had that online. So I haven't got the after photo for this yet, unfortunately, but that amalgam in the middle was huge. So it was decided that would benefit from porcelain only. And that was referred on to one of my dentist colleagues. Okay. And that patient had just come in off the street, basically just knowing that she needed to come. You'll often find that if you're doing kind of perio or hygiene work as well as a therapist, that patients will often, especially nervous patients, if they've not been in a long time, they'll want to kind of try out the practice first. So if you're offering direct access, they often will start with a hygiene visit because they think, right, I'll just try, I don't like that my teeth are stained. I don't like that they look kind of dirty, so to speak. I'll just go for a clean and see what the practice is like. And if you can build a good rapport with them, often they'll be happy to be referred on to the dentist as well. This is another case that was a direct access case. Again, this girl had not been in a long time. She was, I think, in her 30s or 40s as well. And you can see she has some retained deciduous teeth, loads of staining. Again, it was gingivitis, no bone loss, nothing like that. But these on the lowers, sorry, on the uppers, the upper ones, unfortunately, were unsavable and lots of infection. Deciduous tooth removal as well. They had to go. This after photo, people always say, is this the same person? But I promise you, it's the same person. She had an upper denture, so she wants to have implants eventually. She is currently saving to have those. I carried out her periodontal treatment, her direct posterior restorations, and then she saw the dentist for extractions, her denture, and then she will eventually hopefully see that dentist for some implants as well. This is another of my direct access patients, again, who just knew basically that the mouth wasn't healthy. I seem to have a lot of, people that haven't attended in a long time. We see a lot of nervous patients in my practice, so it tends to be, where they come, and as I say, often they will start with a hygiene visit. So this person knew their teeth were stained, knew there was something going on, didn't really know what. Obviously you can see there's a lot of perio problems going on there, a lot of staining. They've got this upper left one that is has been root treated and is discolored. So what we did was I did their periodontal treatment, extractions and internal whitening with the dentist, and then the dentist referred them back to me to do their anterior composite replacement. So they are currently under treatment with the dentist and will replace that anterior composite that now looks well out of place. So I haven't got a photo after their internal whitening yet either, actually, but that will be coming hopefully at some point, still mid-treatment. This is another one. This is more of a cosmetic case. So this guy was getting married. He actually didn't mind so much this composite. He didn't actually care about the shape of it. That wasn't his priority. It was more that he just wanted whiter teeth. Once we told him that if he whitens his teeth, he's going to, want to replace that composite because it's not going to look the right shade. He decided to have the composite replaced, and then he also had, I think it was missing upper left 5, that was referred onward to one of my dentist colleagues. And this is where working really cohesively and having like an open door policy as a team is key, because if I carry out an exam on somebody and they want whitening, my dentists are more than happy to look over their records, come in, see the patient, have a good look and check that they're suitable, and then prescribe the whitening for me to enable me to carry out their whitening and their composite bonding as well. So again, good relationships, absolutely key. But like we say, the dentists are often getting something out of it as well. So it's a good relationship to have. So if you're currently not using your full scope and you would like to, how do you get started? Okay, these are just some kind of key pointers, and they're not all of them are not going to be suitable for everybody, but this is what I would recommend if you would like to start. Okay, so finding the one. Okay, so you may be in a practice where you think that they would be open to the idea of using you to your full scope. That is amazing. Again, it takes some work of working with the team, working with the protocols to get everything in place. You may be in a practice where you think, do you know what, there's absolutely no chance. You might have been battling for years to try and get them to let you, not to let you, but to utilize you fully, Often we are fighting a losing battle. There are some situations where it's just unfortunately, they're just never going to come around. But if you do need to look for somewhere that is going to support you and champion you as a therapist, these are the ingredients that are ideal. So we want to have a good team culture. So, a team that enjoys working with each other, that are nice to each other, that socialize with each other. As I say, open door policy with the dentist. I know I can walk into any of my dentist surgeries and ask them a question. They will also do the same to us, therapists as well. They'll ask us about, would we be happy doing this restoration, or what's the patient's perio like after treatment? All these kind of things. Remuneration is also important. Okay, so you need to be paid for what you're going to be doing. Work-life balance, growth opportunities, support within the practice as well. Their approach, the practice as a whole, their ethos, their approach to patient care, the patient base that they have. So is there, do they have enough patients and, enough kind of scope for you to expand, and the equipment that you have as well. So with the team, how are we going to prepare the team to get used to working with a dental therapist? So clarify your scope with the entire team. Like I say, maybe even just a little kind of lunch and learn type thing at lunchtime and half an hour at lunchtime, depending on what you've got to talk about. Tell them what your scope is, what you can do, let's say how they should be addressing you using your correct title. Allow them to ask questions as well, because often people will think, this is a really silly question, but it's quite surprising sometimes how little, some of the team might know about a dental therapist. So let them ask questions. Like we say, ensure they're all calling you by your correct title. Diary management is important as well. So what can be booked in and where? I quite like to zone my diary. So I will have maybe a morning and an afternoon, another morning per week, where basically it's a kind of zoned area. So that is for non-surgical periodontal treatment, restorative treatment, and new patients, basically. So reception know that they can't put kind of routine exams and things like that in there. And if you get your reception team just completely abiding by that, then it works brilliantly. And they don't book anyone else in there, kind of no exceptions. The reason this is good is that if you, for example, have someone maybe that has come straight in for a new patient exam with the dentist maybe wants to refer some posterior composite to yourself. They then want to place an implant or something like that, but they need the health treatment done first. It just means that you have slots in your diary within the next few weeks that can be utilized to get these patients, your side of the bargain done, and then straight on to the dentist to get their treatment completed. Discuss transition of care. This is hugely important as well. So between the dental therapist and the dentist. So are you going to treatment plan some cases together? How are you going to refer onward if it is something that's outside your scope of practice? And how will patients be educated about the dental therapist role? Some people like to make kind of leaflets and things, posters. Some people like to just do it verbally and, put it in your patient notes. You always should do it verbally as well. Obviously, a poster or a leaflet's not really going to cover it, but there are lots of different ideas about how you can introduce patients to your role. So second thing is feeling confident and competent. Okay, really, really important. The GDC always say, carry out treatment that you are confident and competent to carry out. Research courses to attend to increase your skills and confidence if you don't feel confident. Okay. Ask to shadow others in the practice. Honestly, I think you can learn just as much, if not more, by shadowing an experienced colleague, whether that is a dentist, another dental therapist within the practice. You can absolutely learn lots. I work with 4 dentists and they all do things slightly differently. I've shadowed a few of them, and every person that you shadow does something slightly different. You always learn some little tips and tricks, no matter who it is. Other therapists as well. Really good to shadow other therapists, and we do that quite a lot within our dental group. Somebody will go and shadow someone else, that's at a practice in the same city as them or town as them. Works really well. Practice on a typodont as well. So, if you are a little bit, especially if you've maybe not picked up a high speed since you graduated and it's been a wee while, you can buy typodonts. So, kind of fake sets of teeth, basically, just got a kind of fake mandible. You can buy them on Amazon for about £40 and you can replace the teeth once you've drilled them and things as well, which is quite inexpensive. Practice placing your matrices, your composite, carving composite and things like that as well. Just practice on that if you're really scared to practice. If you're really scared to actually do the treatment on a patient, it can be a really good way of learning. Reach out to colleagues for tips and advice. So, network, talk to people, ask them how they do it. I think we should never be judging each other for not knowing things. I think, I think as therapists, we're quite good at being supportive of each other as well. So, reach out. If you see someone's work online, you think, oh, that's amazing. That's really good. Just reach out and ask them, how did you do that? Or if you see something in someone's mouth in your practice that one of your colleagues has done, ask them how they got such great morphology or, what matrix they used. And you can learn absolutely loads. And discuss with your practice what kind of treatment you're comfortable with. So, let them know if you're starting off, you might want to start, just doing some small occlusals. You might be more confident than that. You might want to do kind of MOs, DOs, you might want to do anterior composites. Let them know exactly what you're comfortable with, because otherwise you will just be referred, anything. And we've all seen, if we've worked as therapists doing restorative work, we've all seen some pretty, questionable referrals from our colleagues, that maybe should never have made it to us in the first place. Find a mentor if you can. A mentor should be someone who can support you on your journey to reskilling, okay? So it can be a more experienced dental therapist. It could be a dentist in your practice. They need to be accessible. So ideally someone you can, call upon if so, say, you've done a treatment and you think, oh, I'm not sure I did this right, or I'd like to know how to do this better next time, someone that you can contact and they're going to be getting back to you quite quickly. And they need to be someone that's going to motivate you as well, someone who's knowledgeable on the topic, so knows about what you're asking them about. They need to be patient, reliable. They really need to want to help you grow as well. They need to be current with their knowledge. They need to be up to date with the latest techniques and materials, things like that. They need to be honest with you as well without being judgmental. So, you need to be able to take constructive feedback and they need to be able to give it so that you can learn and you can grow. And as I say, when you think, you can probably think of somebody, most people probably think of somebody that they could ask. Build a support network as well, okay? So, people that are outside of your practice. So, go into conferences, in-person meetings, webinars like this, join in an association, online groups, social media, which can be both good and bad. We'll talk about that a little bit later as well. Reaching out to peers, colleagues, loads of people that you can use as your support network. I can think of quite a few people that for certain situations I would reach out to. I kind of know who I can reach out to when, and it's great just to have that support when you're starting out. Okay, so discussing your role with patients, and this is really, really important. So patients need to know, briefly what a dental therapist is, what we can do and what we can't do. Okay, so introduce yourself. Explain that we are trained professionals who work alongside dentists to provide a range of services, okay? They also need to know what your responsibilities are. So you might say something like, dental therapists can perform routine dental care procedures such as hygiene visits, fill-ins, and preventive care, and that we are patient educators and help you to maintain your oral health. Talk about our qualifications very briefly, because I guarantee, most patients will not know that you have to go to university to be a dental therapist. A lot of patients will think that, maybe it's a on-the-job training, like a dental nurse, something like that. Say we've got specific training that allows us to work effectively in dental practices, and you will have done a degree or a diploma in dental therapy. Talk about the benefits. So having a dental therapist on the team will allow for more efficient care. So we can handle many of the routine tasks, which can mean that there's a shorter wait time to have things done. And then also reassure the patient. So, always reassure them that anything that is outside your scope of practice, they are absolutely still able to see their dentist at any time, So I will always say to my patients, if you're worried of anything, in between visits, you have any pain, any discomfort, anything that you want to ask us about, absolutely just get in touch, and you'll be able to see either myself or your dentist. It's always just having that kind of, reassurance from them as well, if they're not used to us. So start small. If you've not been doing restorative work for a while, you can start with referrals from the rest of the team. So it's quite a nice way to get going if you're not quite comfortable in kind of treatment planning yet. You can ask a dentist to grade restorations. So again, if you just want to start off with occlusal, so you could have something like, a grade A as an occlusal, a grade B is a kind of shallow MO or DO. A grade C is something that's, quite near the pulp and quite difficult, maybe subgingival, something like that. You can make up your own kind of system so that they know what they can send you and what they can't. And as you gain confidence, you'll want to increase the difficulty of what you can do as well, okay? But always keep them informed of, how you're feeling, what you feel you can do, feedback on what you've done as well. So, if they're seeing the patients after you've done some treatment, ask them for feedback. So check your setup and equipment. So if you have been working hygiene only for quite a while, often, practices will have surgeries that maybe are the hygiene room. Maybe the high speed hasn't been used in a long time. Just check that everything's working before you start. Okay, so it's always easy to get an engineer to visit just to check settings, check that all the water and the air lines and everything are working properly, and just check that your handpieces are of good quality and they need to be well maintained as well. Look at your kit, okay? So good equipment that you like to use makes your restorative work so much easier and more enjoyable. Personally, I am a fan of buying little bits and pieces myself. I think especially if you're a self-employed clinician, obviously you can kind of claim that back against your tax as well. I think maybe I'm just quite anal. I quite like to have things that I like and also things that are only mine that nobody's going to break or lose or ruin, So um, we'll talk through a few different things. But again, start small. If you're just starting out, use what the practice has. You don't have to go buying things immediately. But these are things that I like and that I found have been amazingly beneficial to my practice. So Kerry's detector dye can be amazing if you are just starting out and getting more confidence. So aids in the excavation of decalcified and infected caries dentine layer. Okay, so optimal caries removal. So basically what this will do is you can see in this picture, it basically stains any carious dentine pink so you can see exactly what is left. Okay. So it helps to minimize the removal of healthy dentine. So we're always talking about being minimally invasive nowadays, and this really helps us with that, and conserves the maximum amount of healthy tooth. Okay. And this one is the Carrare caries detector dye, but there are a few different ones on the market. Sectional matrices, okay, so most practices will have these within the kit, okay. Go and have a look around the practice. If you're not sure what there is, talk to your colleagues that might be using these already. Sectional matrices in general will help you get a really nice contact. Sometimes, depending on the situation, there is still a place for your full bands, your circumferential bands. Still definitely a place for those in certain situations, but for your kind of standard kind of MO, DO, sectional matrices are amazing. So they come in different kind of curvatures, different sizes, different depths. This is the Polydentia Quick Matte Forte kit from JNS Davis. So they have basically everything in one. So they've got your little clamp, they've got your matrix bands, and they've got wedges. You also then get the kind of the pliers and things as well with it. So if you've not used sectional matrices before, again, get yourself a typodont. Ask one of your colleagues to help you start placing them. And that's a really good way to learn how to matrix. This one on the bottom, so just get my pointer. Where are we? Just here, this one. So this is the Polydentia My Clip. So with this one, you don't need the pliers to place it. You literally just squeeze the ends of it and you can place it on with your matrix bands. This is a really easy one to start with as well. You'll see it's a little bit bigger, so you do need a bit more room to place this one, but it can be really kind of easy to get started with, so you're not fiddling around with your pliers and things as well. Instruments, okay, so composite instruments. These are the ones that I like. These are the LMRT instruments. Again, they're from JNS Davis. I find that sometimes, one or two of these is all I need to do a restoration. The top one is a solo posterior, so it's basically meant to be an amalgamation of kind of what was everyone's favorite from the full LMRT kit. So I'll show you in a second just a little video of how that's used. You've then got your solo anterior, which has got this lovely big kind of flat paddle shape on the end, the yellow one in the middle there, which is really great for doing kind of composite veneers, composite edge bonding as well, just to really shape things. And then the mini spatula is just a really fine, thin, flat plastic, basically, which is lovely to use for placing composite. When you're kind of placing it up against the matrix band, you've got that really, really tight area to pack it into. These are really, really great. So I'll just show you on this video. This is just a posterior restoration on a typodont. It's just a 7. So you can see we're just doing the lower 7. You can use this little end, just like we always say, it's a bit like a knitting needle, going up and down, going along, basically just to make the fissures like this. And then you can use this curved end basically to shape the cusps after that and smooth everything out. So really, really nice instrument to use, one that I really like. Polishing, again, if you've not been doing much restorative work, you might find that your surgery doesn't have any of these things, but I can almost guarantee you that the dentist surgeries are full of lovely, lovely polishing gear, especially if any of them are doing anterior restorations, kind of veneers and things, or composite veneers and things like that as well. So everyone will at least have some soft flex discs probably in their surgery. Those are great to start off with. There are also these lovely polishing wheels. These are the Mysinger ones. With these kind of polishing wheels, I love these. I think they're amazing. There's so many different brands, but in general, you'll start with the darker color and work to the lighter color. Okay, so in this case, you would start with the pink and work to the kind of white, beigey ones. You also get ones that are kind of dark blue and light blue and things like that as well. They basically act a bit like your soft flex disc, where you might use a soft flex disc first to shape everything to get the kind of primary anatomy, and then you might refine things down, and then once you're kind of doing your final polish, you would use these twists basically to refine the surface. So they give this really lovely high gloss finish. You have things like your one glosses as well, your interdental polishing strips, loads of different things. And again, no one is the same. Everyone likes different things. You know, again, all the dentists I work with love different things. So it's just trying them out and seeing. Again, if you get yourself a type it on, try on that, see, you know, how it works, how they bring things up, and just see what your favorite is. These are things that I would say are nice to have, but are not in any way essentials. Composite modeling brushes, amazing for getting a smooth finish, really, really nice. You can use those alongside this liquid at the bottom. This is a Signum liquid from Kulzer. This is like a modeling resin, so basically like a clear fluid that's got a bit of a clear resin that's got a bit of kind of slip to it. So basically, you know, sometimes when you try to shape composite and it just feels really sticky, this gives it a lovely kind of slip. So you can glide your instrument over the top of it to make it smooth. You can use your composite brushes to make it nice and smooth. It's really nice stuff to use. You also can heat your composite if you like to do that. I think this is the Brian Dental one. I don't have this. I would like to have this, but I don't have it. There are loads of different composite heaters out there, lots that are inexpensive and lots that are expensive. If you like to heat your composite, you can have a little look. There are many, many on the market. And again, you might find that there are some in your practice already that are not being used that you can pinch for your own practice, for your own surgery. Document your work. So take photos of your work. Again, this can be done on a phone. For GDPR reasons, it should be a phone that is not connected to the cloud, so not your own phone. It needs to be a practice phone, or just an old phone. Maybe you have an old phone, you know, that is lying around at home that you could take photos on. Just make it your work phone. It does help track your progress and your improvement as a clinician over time. This is the last slide, and I think probably one of the most important slides of all. The most common reason that dental therapists tell me that they're scared to start is because of what they see on social media. So I said earlier that, you know, social media can be both a blessing and a curse. This is where it's a curse. Some therapists can be really intimidated by what they see online. What I think we need to always remember is that a sealed and functional restoration is the most important thing for our patient. If it is well sealed, it's not leaking, it is functioning for our patients. That is all we need. You know, you will see things on Instagram, on Facebook, that are these beautifully carved, amazing, impressive composites. By all means, if you can work up to doing that, great. You know, we always want to try and recreate morphology if we can, but just remember that sometimes it's not possible. So if you're removing a really flat old amalgam, it might not be possible to make beautiful cusps because your patient's bite's going to be high then. So, you know, just, you know, I would say work to the beat of your own drum, you know, focus on yourself, look at your progress as a clinician, and just don't be intimidated. Just start, basically. Have a good support system around you to get going and go from there. All right, so that would definitely be my main piece of advice, because I know it can be really intimidating, but please don't be intimidated. I mentioned before that I run a course called Restore. So this is a reskill course for dental therapists. We are on Instagram, restore.dental.course. Our next one is at Action in St. Neots. It's only actually in 2 weeks' time, so I know it is cutting a bit fine. We are mostly full, but there are a few places left, last couple of places. It basically consists of online modules, And then the hands-on, like I say, is on the 5th of April. And we're actually running this one completely for Bridge to Aid. So no kind of profit for us from this. We are doing it to raise some money for our trip to Tanzania, which will be next year. Some of the NSK Ikigai educators are off to help with an oral health education program out there in January next year. So myself and Ibrahim are running the course for the benefit of that. If you're interested, just send me a message. This QR code will take you to the booking page if you want to look at it. But yeah, just drop me a line if you have any questions, or you can attend at such short notice. There's a discount code for the NSK web shop from NSK. Thank you very much to them. And this will give you 40% discount for anyone who has attended this evening. So it's written in the middle there. So I'll give you just a little second just to note that down. And that is valid until the 3rd of April this year. Okay, so a couple of weeks to use that. And that's valid, I believe, on everything.
I've also put that in the chat box as well.
Thank you,
If anybody
Catherine.
wants
Amazing.
to have a look
Thank you.
at that.
And then just thanks to JNS Davis as well, because they support the Ikigai Oral Hygiene Programme. A lot of the things that I spoke about tonight are their products as well. So please do get in touch with them if there's anything that you want more information on. They're very lovely people, so they'll help you out. And these are my contact details. Just last thing, if anyone wants to contact me, I'm on Instagram and that's my email address. I am fully open to be contacted at any time. Please do just reach out if you need anything, if you have any questions that we don't manage to answer tonight, and we can go from there. But yes, it's been lovely speaking to you all. I think have we got any questions, Catherine?
We have, yeah.
Unshare. Hold on. Let me see.
Honestly, absolutely amazing though, Lauren. Your knowledge and just how you presented that is just so good. It really, really is. Really, I mean, obviously, I'm not a therapist, but just really easy to understand. Really, really good. Before we start the questions, I'll just say, and I will remind at the end, that this is recorded. It normally takes around sort of 10 days or so for this to be uploaded onto the NSK website. So do give us a little bit of time just to get that sorted out. Also, you will get an evaluation form in a couple of days, probably now, early next week, given the fact it's Thursday. So just have a look out for that. Do check your spam and your or junk folders, depending on which you have, just to make sure that you get that. Once that's filled in, you'll be sent your CPD certificate. So yeah, we've got good. A few questions.
Okay.
Can dental therapists be trained to do Invisalign?
No, that would be outside scope of practice. So anything that is orthodontics, we cannot do. Now, some indemnity companies will say that you can place the attachments for Invisalign. However, that is very, very dependent on your company that you're with, and you would have to ask them and check. But yeah, anything orthodontic is outside of scope, so you can't treatment plan for orthodontics of any sort.
Right, I'm just going to say, if it's possible, can we put any questions into the Q&A? Just because I've got a couple of questions in the chat box, but I will get to them. Also, Lauren, while she was speaking, somebody was asking about local training, exemptions. So I have put the link into the chat box. Just to let you know that when you go into that, as I think I'm correct in this, but Lauren, you might correct me. I think you have to register first.
I think so, yes.
Then you will get a link sent to you, and then you're able to.
Yes. So I think if you have an NHS online account, you can log in.
Right. Okay. Okay. So that's possibly why, because I don't. Yeah.
I think.
Yeah, that's fine. Okay. So we've answered that one. If we refer to another hygienist or therapist, do they need to do a full exam again, or do they follow the treatment plan by the referrer?
So you can, as I say, you can refer to another therapist, another hygienist. They can follow your treatment plan as a referral, but as always, you need to be confident that the treatment that you're carried out is the correct treatment. So, you would always you don't need to do the full exams. You wouldn't be taking like new radiographs and things like that, but you would examine the patient to make sure that you're happy to carry that out. Okay. If that makes sense.
Great. what about dental plan patients? How do we sell it then? I'm assuming that's sell it to the dentist.
Mhm. So plans can be difficult. It's really sitting down and working out basically what the practice is
Mm.
bringing in from those plans and how you're going to arrange it. It is definitely a lot more difficult with plans. When it's kind of fee per item private, it's much easier. So again, sit down with them, work out, because a lot of the time the associates might be getting kind of, their percentage for what's coming into the
Mm.
practice from the den plan, and they might not want to share that. So that's where the difficulty can be with that. But sit down with your practice owners and discuss, have an open conversation, because I think sometimes we're really scared to talk about finances, and that's where we get stuck sometimes. So I always think, sit down and have the conversation. The worst they can say is no.
Yeah, know your worth as well.
Yeah,
Yeah.
absolutely.
Debbie says, excellent webinar, Lauren.
Thank you, Deb.
And then we've got Beverly who said, hi, could you repeat the matrices again that you use, please?
Yes, so that was the Polydentia Quick Mat Forte. Those are from JNS Davis. So if you go on JNS Davis website and go to the matrix section, they'll all be in there. And then it was the Polydentia My Clip as well, which is the one that you don't need the pliers for.
Okay, brilliant. So it's a bit of a long one, so I will try and get through this. Working with a dental therapist, working as a dental therapist in the NHS UDA system, feeling a bit down, as if there is treatment outside my scope, I have to send the whole course to the dentist after doing the exam. Also get lots of emergencies booked in with me that are often RCT or dentures that I can't do. Feel like it's a waste of my time and patients' time, and have had complaints because of this. Also not allowed to do private posterior restorations. I like treating children, but scared to approach principal to request peds only. Any advice, as feeling like giving up therapy sometimes, which is
Oh,
sad.
this makes me really sad.
Yeah.
This is an issue with the triaging in your practice, I feel. So reception should be prime that, they will ask the patient specific questions. So, are you having pain? Okay, yes, you're having pain. Is the pain lasting for longer than a few seconds at a time? Okay, it's probably going to be an irreversible pulpitis and it's not going to be booked in with a therapist. If it is your practice principals that are telling them to book them in with you, then again, that needs to have a conversation, because it's again, like, you're completely correct that it's not a smooth pathway for your patient either if they're seeing you and you can't help them. So for patient's best interest, really that patient, in my opinion, should be seeing a dentist. I think it needs to sit down in a conversation. It's not an easy thing to sort out with the NHS either. I think, like I said earlier, there's a lot of there are a lot of things that still need to be ironed out with working under that system as a therapist opening course of treatment. We're often not remunerated as well as the dentists are for it. And like you say, you're working under someone else's performer number. It's, you're saying obviously if you see something that's not in your scope, you're having to send the whole lot to the dentist. There are ways around that, but maybe that's just how they've set it up in your practice, which again needs a conversation, because like you said, that's not particularly fair on you. And I would just say, well, Catherine said before, like, know your worth, don't, have a conversation, speak to them about it, and just, set out why. But I would say the go with the facts, go with a list of things that you want to say, because often it is really intimidating to sit down with them, and if they're your boss, or if you don't have a particularly kind of open, good relationship, I would go with a list, or even just, send an email with a list of things and then ask for an in-person conversation as well. That's how I would approach it.
Right. Okay. Not easy though, that is it. That's a difficult one, I think.
Really hard, really hard.
Yeah. So Laura's asking, I think maybe Laura trained with you.
She
Um,
did.
many moons ago, apparently.
Yeah.
Not as many moons ago as me, but okay, so how do we train to do routine exams?
So for undertaking exams, depending obviously what was, we know back then we weren't really, trained to do routine exams. There are courses you can do. you can train on the job as well. So, basically go and
Mm.
look at your dentists and what can be quite good, shadow them, then look at their treatment plans. If they're willing, sit down with them and say, right, let's look at these x-rays for this patient that you took. This is what we saw. This is what we treatment planned. And just getting used to it like that. Shadow them whenever you can. If you need to come in a day off or you've got a gap in your book, just get in with them and get them to teach you. But again, that requires having a lovely team that are happy to do that. But a lot of dentists are can be a little bit wary about letting go of the exams to start with, but actually when they get rid of them, they are delighted and are more than happy to pass them over to us. So again, it's just getting their confidence in you up as well. I hope that helps.
Okay, so any training available for prescribing, taking and grading radiographs, please?
There is, of course, I think it's Jimmy Macadissi, is
Yeah,
that right?
sure.
JM Radiography, if you Google, runs that course. I think that's the
Oh,
only one I know of. I think deaneries and things might run them sometimes too, but that's the one that I know of.
I think there's been quite a few inquiries about that, and I think there's not a lot going on at the moment with it,
Okay.
but yeah.
I suppose if enough people email and say, please.
Exactly, yeah, that is true. Enough interest, I'm
Please.
sure. How do you make occlusal of a composite anatomically functional to give maximum intercuspation even?
That is a question that you could spend hours answering.
Okay.
And not easy to explain verbally. So I would say if you are struggling with that, get yourself on a composite course that is also going to talk about occlusion as well. Most of them will. But
Mm,
yes, if you can find a course, then yeah, I would think that would be the best thing because hands-on is the best way to learn that really, and to do a bit of learning around occlusion as well.
mm. Do you do occlusion on your course? The one
Yes.
that you're doing? Yeah, yeah. Perfect. Okay. Marvelous. How can we explain to a patient why they would pay for an exam with a therapist when they can see a dentist for an exam?
This is again about valuing yourself and basically saying it needs to be the norm basically. So patients do not quite believe me, patients do not question it when you say, if say you're kind of moving over to a therapy-led model, when the dentist says to that patient, look, the therapists, I'm now going to pass you over to Lauren, I'm going to pass you over to whoever, and they are going to carry out your routine examinations. I will always be here if you need me for anything that is outside of their scope. Patients are absolutely fine with that. Once they meet you, they get to know you, they find out that you're a nice person, that you can look after them just as well as their dentist did. They're absolutely fine with that. They don't tend to question it. I don't think that we need to justify ourselves too much because again, I think sometimes when you talk too much about it, people, patients then think, oh, why are they trying to over justify it, I think again, having reception primed as well of what you do and how highly trained you are, respecting your skills, is key as well. Because when patients ring up, they should then have a little spiel that they can say to the patient of why the therapists are doing the exams.
Yeah. Are you all right for a couple more questions?
Yeah, go on.
Yeah. Okay. So as a dental therapist, can we do edge bond, composite bonding?
Yes, no problem.
Yeah. If I had a referral for a filling that I wasn't sure to do it, should I refer back to the dentist?
Yes. So again, competent and confident. If you're not confident and your gut is telling you it's not within your capabilities, send it back.
How do you get a good seal in the base when after matrix and wedge there is still a gap at the bottom?
So again, this is probably more about matrix selection. So, having a range of different matrices. Again, though, this is more a hands-on, have to be shown practically type question. So again, I would go on a course that includes matricing and guidance on that as well, if you can.
Yeah, some of these are quite difficult, aren't they, when you can't
Yeah.
you've not actually got the there's things there. So, how do you know which articulating paper marks to adjust?
So again, more of a hands-on question, but generally, if it's on the tips of the cusps, then that's fine. If it's outside of that on your restoration, then you want to be looking at your, how things are contacting. So say it's a lower tooth and, you want to look at the upper to see if there are any kind of malalignments and things like that. But again, definitely easier on a hands-on course. And there are lots of, even aren't hands-on, but lots of detailed occlusion courses as well. So yeah, absolutely.
Okay. How would you persuade your practice managers to work to your full scope when they have made it clear they cannot pay you a percentage and pay you per hour?
So this is again tricky. So I am a big fan of a percentage because I think that as the practice puts the prices up, as you are utilizing more of your skills, as you are working harder and doing more tricky procedures, you should be remunerated for that. If they are really sticking on that and they are deciding that that's not what they want to do, then you need to have a think about whether that, you're happy to do that. You're happy to stay on an hourly rate while doing more and harder, more complex work and making them more money, or whether you're not happy with that. Because sometimes they just won't shift on that.
So I think the next few, I think I know what you're going to say, but obviously I'll ask them. Any tips for quick anatomy on posteriors?
Yeah, so instruments like the LM solo posterior is quite the method that I showed there again, which we talk about more on the course as well, is a good way of quick modeling. It's the Style Italiano method that they kind of push, and it's a really easy, quick way to model, but again, easier to show hands-on.
Right. How do we create line angles on upper centrals?
A hands-on question.
See, this is what I
Definitely, it's
said.
so
I thought you,
honestly,
yeah, it's so
I'm so
difficult.
trying not to be awkward, but it's
Yeah,
so much easier to explain
yeah.
on a hands-on course, honestly.
And the next question is, where is the hands-on course in London that you're doing?
So it's in St Neots, which is not in London, but
Oh, is it not? Okay.
I'm like, it's somewhere down south.
It is it? Yeah.
Please Google
Us
Action.
Northerners.
It's Action UK in Google Maps, and it will show you exactly where it is. It's there in 2 weeks' time on the 5th of April, and like I say, couple of places left.
Okay. Is the powder containing aluminium harmful to inhale?
So this person is probably talking about sandblasting, I imagine. Yes, I wouldn't really want to be inhaling it. Just usual mask is fine though. You just need to put a mask on.
Just like a fluid
And
resistant.
good suction from your nurse. Really
Yeah,
good
yeah,
from
yeah,
your
like a
nurse.
wide bore.
It does go a bit everywhere though, but yes, good suction as much as you can.
Yeah.
Yeah.
LA provided through prescription. Can we administer it if prescribing dentist isn't present at the time?
Yes. Yeah.
Okay. Do you recommend any good Instagram accounts to follow for restorative work?
Loads of good ones. There is the Style Italiano one is quite good, quite aspirational, but quite good. They show some very impressive stuff on there. The LM one can be quite good, actually, the instruments as well, because they show lots of videos on how to use the instruments as well. I don't want to particularly name any. There's so many great dentists and therapists out there. I would just go and have a look and see what, because again, I feel some of it can be a bit intimidating, and I think it's looking around and seeing what kind of
I
level
think
you're at, and if you can see if someone that maybe is doing things that you feel could be achievable for you.
you're absolutely right though, because I think anything Instagram wise, no one's going to post the rubbish, are they?
No, that's
So
exactly it as well.
this is
You have
it,
to think like this is the people that are posting a lot, and the a lot of restorative, like they're posting their best work, right? They're not posting the thing that, like I said earlier, if you're taking out a really flat amalgam and you can't replace it with a lovely carved composite, they're probably not posting those ones.
No, this is it.
And then when you do one that looks like that, it makes you feel a bit rubbish sometimes because you think, oh, well, this person had that, so I think some of it can be a bit intimidating.
Yeah, definitely. So you mentioned that therapists opening cots can you guide where that is in the NHS, as I couldn't find it?
So if you're in England and Wales, you can open a course of treatment in the NHS, again, in collaboration with your dentist colleagues under their list number. There is a whole, if you Google NHS England dental team working, there's a whole section in educational videos and all these kind of things on that.
Say that again, Lauren, and I'll write it in the chat. NHS
It
England.
is, I'm actually just going to quickly check what it's called. Just check that it does come up.
Mhm.
Team working. Da, 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 yeah, so it's skill mix in NHS general dental practice.
Okay, so let me
Supporting
write
skill
that in the
mix
chat. So skill mix
in NHS
in
general
NHS
dental practice.
general dental practice.
Yeah.
Right, let me
If you Google
just
that, there's a whole section online about kind of
general
NHS rules and things
dental.
and how to do it.
Lovely. Okay, there we go. That's in the chat. So could you suggest a composite course for therapists, please?
So obviously there's the one that I run, I just mentioned. There are also lots of I've been on loads myself though. I there are lots run by therapists nowadays, but I don't think that you have to go on one that is specifically for a therapist because I think we should be able to join in any composite course that is for direct composite that are run by dentists as well. There's some amazing dentists running course as well. Someone that I really admire who does amazing composite work is Ahmed Tadfi, and he runs a course with another dentist, um, which is an amazing. I think he's Dr. Tadfi, so Tadfi on Instagram, and his courses look amazing. I actually haven't been yet, and I know I think the incidental composite course is meant to be really good as well. It just depends what you're looking for because a lot of them will purely be hands-on placing composite, a bit of occlusion and morphology. It just depends what you want out of it. So I would say just look at the aims and objectives and see if it suits you.
How do you block out dark colour buccally when changing amalgam to composite?
So do you mean on a posterior tooth, I'm presuming?
Say here,
Yeah,
so
yeah, it must be if it's amalgam.
yeah.
Sometimes you can't. Sometimes because we're being minimally invasive, we're not just removing things because they're a bit stained by an amalgam. Again, if it bothers the patient, you need to have a discussion about that. Obviously, amalgam does leach into the tubules, it stains things. Often there would be no way to remove that without just, removing a lot of healthy tooth tissue. So sometimes you can't.
Okay. What whitening gel would you recommend?
Any of them.
I
I actually
love that.
don't.
Sit on the fence.
No, I don't actually
No,
don't
yeah.
have an affiliation to any of them. And obviously with the maximum percentage being 6% hydrogen or, 15.8% carbamide or whatever it is in the UK, it's finding one basically that you like to use because some of them are different consistencies. Some of them you'll get the trays included. It just depends on what you want to use. I mean, you will get good results from most systems if you're using the correct percentage, I feel.
Have you felt devalued at workplaces through your journey? If so, what did you do not to let that become something you started to believe?
Yeah, absolutely. Like I say, when I was doing like 15-minute, 20-minute, conveyor belt hygiene appointments where no one was even getting, there was no scope to say this person needs perio treatment, can I have an hour? Or, there was none of that. That was all just getting referred somewhere else pretty much. You it's really hard. It's really hard not to let it get to you, because if you feel like that, I am a great believer in that. I think your environment massively influences how you feel about yourself as a clinician. I think if you feel like that, then somebody or something is making you feel like that. And you maybe need to look at the environment that you're in and have a think about whether it's actually the place for you because we've all worked in, kind of toxic workplaces, I suppose I would call them, where the culture is not good, the team are not supportive. I've worked in places where there's no way that I would have walked into one of the dentist's surgeries and asked them things, just no way, because they were just so unapproachable. It was that again, I'm a really big great believer in the team all being on an equal level as well, because the places that have been the worst places I've worked are the places where there's this huge hierarchy where basically the dentist is God, so to speak, and you can't question them. You can't, not question them, but you can't,
Mm,
ask them
yeah.
why they did something or say that you would like to do something this way. You're just not allowed to do that. And you're not seen as an autonomous clinician in your own right. You're basically being told, do this. And as we all know, like we've said multiple times tonight, if it's something that you don't believe you should do or you don't believe in doing, then we shouldn't do it. But I've been in those situations where you feel like you have to do things because someone is telling you you have to do it,
Mm.
and makes you feel a bit rubbish about yourself because you're not doing what you should do. So yeah, I think look at your environment and the people you work with. And it's not easy because, I could sit here and say, oh, go and find a new job, but it's not always that easy. You can't just walk into the ideal situation sometimes. But I think it's an awareness of that maybe the environment's not right for you and that you would like to look elsewhere and just really keeping an eye open. And when that thing comes along, going for it.
Okay, just a couple more. This is very similar to a couple of others, but because it's just got a little bit of a nuance here
Okay.
about encouraging other practitioners in the practice to send you their NHS patients
Mhm.
or to do private composites.
Again, it depends what they are doing. So with dentists, they will always want to be doing something. When I say better, I mean probably more financially
Yeah, yeah.
beneficial for them. If they're going to send you those things. So it's being in a practice where that is viable and also, letting them see that doing this frees up their time, so that if they want to do a 4 hour veneer prep or whatever it is they want to be doing, or fit a few Invisaligns per morning to make a bit more money, then they can do that by sending things to you. But it's super tricky to get started if you're not in that environment. But again, conversation, communication with them, ask them what would incentivize them to send them to you. And I
Mm.
don't mean financial because they're not allowed to be paid to
Mm.
send things, but what could you do for them? Can you talk to patients about the treatment that they love to do?
Mm. Great. Recommend amalgam replacement in a capsule.
Not quite sure what that person means.
Okay, so if that person wants to maybe just clarify what you mean, and then we can come back to it. How do we make basically, is there a good flow chart?
Hmm.
And how do we make the principal know our worth? And obviously get them to try and consider incorporating a dental therapist.
So I think, like I said earlier, there's no one set. The reason there's no flow chart is because there is no set template on how to incorporate this into practice. I think you need to have a think around how your practice operates as it is and what would make them see you working to your full scope as a benefit and go from there.
How do you mask out margins on an anterior composite? And do you reduce stain and how do you reduce stains around these margins and joints?
So that's going to be all about your prep and hands-on question, really. So kind of beveling your margins, not having kind of sharp margins and things like that. But again, hard to explain verbally.
Yeah. I'm going to skip one for a minute. So, where did you or who did you study your PGDip with?
Smile Dental Academy. And there are courses in Watford and Manchester for them.
Okay.
You do it a couple of times a year.
What do you say, or what would you say to a principal to ask for a pay rise?
This is where I'm a fan of a percentage. So as the prices go up in the practice, so does your pay. If you're not on a percentage, then and you're on an hourly rate and you want to negotiate, you need to again go with the facts and figures. Has the price to the patient gone up? Have you gained more skills? Are you speaking to patients about other treatments and sending those on to the dentist? All those kind of things, because as annoying as it is, that is what will be listened to at the end of the day. So I would do that.
implant dentists who place implants in perio patients or orthodontists that start ortho in perio patients. Can I see the patient for scale and OHI and then refer back to implant or orthodontist stating I'm unable to manage the patient without getting into trouble?
So I'm just trying to work out what you mean. So you mean as in they've got perio, they're having treatment, and you're just saying you're seeing them for a kind of a routine visit. Is that what we mean? And then sending them back?
Yeah, I'm sort of reading it, Lauren, as though the patient has possibly had treatment done when they're periodontally unstable,
Yeah.
and the therapist is concerned that her involvement in the case would cause her liability.
I think
Because
as long as you inform the patient what's going on in their mouth, which I know can be really difficult, but at the end of the day, you have to cover yourself. You have to tell them if they have periodontal disease. You know, if you're not telling them, that's the worst situation. I think so. You can do it tactfully. You know, you don't have to say anything about the other treatment they're having. You just say, this is what I see now. This is what I see today. This is what I would recommend treatment-wise. And that's where you can leave it. But as long as you've diagnosed and given them the option of having treatment, if it's something that you can do, then I think you're okay. But yeah, again,
so
this is a conversation to be had in practice as well about treatment planning and, yeah.
so loops and magnification for fillings.
I have 3.5, I think, loops. I'd like to go up to 5 maybe though. So I would get a rep to come in, try them on, see what you feel. But they do feel weird to start with though if you're not used to them at all. But I have Bryant Dental ones and I really rate them. I really like them. I've had them maybe 5 years and they've been perfect. There's loads of different brands though. So again, even get 2 or 3 reps to come in, try them on, see what works for you.
Okay. So back to the amalgam capsule one. So amalgam is in a capsule. Are there any quick alternatives instead of composite?
No, not really. There are bulk fill composites that you can get now, that you can cure to a depth of about 4 millimeters, I believe. So rather than having to build in small increments, you can bulk fill with those, which is used a lot. I know in NHS practice when time is a bit limited as well. So you could look into those and just look at the research around them and things as well.
Great. Okay, so I think we're probably better to wrap it up. So if anybody has asked a question and they don't feel it's been answered, there is a couple. This is probably, I'll ask this one because it's just going to be a straight yes or no, I think. Can a dental therapist place a crown?
No,
And
inside scope.
unless they're thinking a whole crown?
Oh,
Okay.
yeah, well, yes, stainless steel crowns on deciduous
Yeah,
teeth, yes, but as in indirect restoration on permanent teeth, no.
yeah,
You
okay.
can temporarily re-cement it, but not prep in place, no.
And with the new exemptions, can dental therapists prescribe Durafat toothpaste?
You can't prescribe Durafat toothpaste, but you
Because
can supply. So we just need to be a bit careful about the language we use around exemptions. So it's never prescribing from us. So even if you've done your training, you're basically using and supplying. So it's never prescribing. So just be a bit careful on how you word that. But supplying to a patient, you can, yes. There are some rules and regulations around that as well, though, and I would do the course and that will be all explained within that.
brilliant. Thank you so much, Lauren.
Problem.
You've done a marathon of
So many
questions.
questions.
Well done. You're going to need to go and have a lie down now in a dark room, definitely. Thank you so much for everybody who's stuck
Thank
with us,
you.
because we've still got pretty much everybody who started the webinar. So that's amazing. Thank you so much. Obviously, a subject that really is hitting the point there. So that's fantastic. So just to remind you that we are recorded. It will take about 10 days for us to get this up onto the NSK website. So do bear with us. You will get an evaluation form via email that you use to register for the webinar. and that should be around Monday, Tuesday, possibly Wednesday next week. Check out your spam and your junk if you don't seem to have got it. Once you've filled that in, you will get your CPD certificate. And just to say, absolutely brilliant webinar, Lauren. Thank you so much for your time, and thank you so much for everybody who has stuck with us. And happy World Oral Health Day.
Thank you. And thank you for hosting, Catherine. And thank
No
you for
problem
all for
at
coming
all.
and staying.
Brilliant. Okay, good
Right.
night,
Have a lovely
everybody.
evening.
Have a nice
Thank
evening.
you. Bye.
Bye.